Thank you for joining tonight's webinar. We will be getting started in just a few seconds, minutes, more like it. Good evening, everyone, and welcome to tonight's webinar, When Patients Understand Their Disease, Prevention Changes, AI's Role in Diagnosis and Communication. I am Linda K. Tyler, Director of Business Development for ASDA, and we are glad that you have joined us as we have a very informative and interactive presentation planned for you this evening. During the presentation, we do encourage you to ask questions via the Q&A feature that is located right at the bottom of your screen, and that's where you can submit your questions. We'd like to thank Philips Sonicare for sponsoring tonight's webinar. And now I would like to introduce our presenter, Dr. Adam Burr. Dr. Burr is a practicing dentist, educator, and industry advisor focused on integrating technology into clinical care and dental operations. He currently serves as Chief Clinical Strategy Officer of Silver Creek Dental Partners, where he leads clinical and operational strategy across a growing multi-office organization. Now, Dr. Burr has over 15 years of experience in private practice and group dentistry, including prior roles with Pacific Dental Services and Elite Dental Partners. His work centers on implementing AI-driven diagnostics, clinical documentation, and communication systems that improve patients' understanding and practice performance. He's also the founder of Vera Dental of Riverton and regularly lectures on artificial intelligence, preventive care, and modern clinical workflows. It is my honor and pleasure to introduce and welcome Dr. Burr.
Thank you, Linda. Thank you, ASDA, and thank you, Philips Sonicare, for making today possible. But more importantly, thank you as student body for taking time out of busy evenings where you inevitably have projects to be done, homework, tests to study for, board exams, and clinical work that still requires follow-up. So I hope that in the next hour, and I intend to make this next hour informative and to give you something that you can take away with to improve your clinical practice. As Linda said, I work in this area, and this presentation is a culmination of what I've done over 15 years in areas that I'm passionate about. Ultimately, I believe firmly that dentistry can be better at helping patients understand their disease. We can do that through some of the modern advancements that we've seen come out over the last 10 years or so, and it helps to improve our communication with them. We'll go ahead and get started on this. We'll initiate the discussion, though, with a brief set of disclosures. I'll leave this up here for 10 seconds or so. These are some of the companies that I work with where I do receive compensation for being involved with them. What we intend to get out of today's discussion is to recognize how AI supports early identification of disease. And then we'll talk about how that helps to strengthen our prevention-focused care. The most important part in my mind is how we communicate that to our patients. We'll talk about the different AI tools, and then we'll connect that with a closed loop on how that actually changes at the patient's home care level after they leave our chair. So for many of you, you've had a chance to be involved with patient care now in your clinic at school. Many of you have shadowed, you've been assistants. Some of you may even be hygienists or dentists in other countries. And the question that I've asked myself is, we, as dentistry, as a profession, we believe in prevention as the foundation of what we do. But when you look at what most of us do on a day-to-day basis, it's actually to restore or treat an irreversible condition that has gone too far. So we talk about prevention, but it doesn't translate to preventive care often. And we're going to talk a little bit more about why that has been the case and what can be done today to change that. We're going to talk about how AI helps to change that conversation. And these are things that are happening across the country. And then finally, we'll talk about this not just as an idea or as a nice to have or something that sounds good, but really what happens in the chair. We'll talk about practical ways that you can make improvements tomorrow, knowing that you don't have control over which tools are in your schools and in your clinics, but you'll still come away with ways to improve what you're doing. So with that, let's get into the first talking point. So we mentioned that prevention is a lofty goal and an aspiration, but what we haven't talked about is, why does it fail? And I would posit that the first and major reason why prevention only works, or sorry, why it fails, is that patients don't believe that early disease is real. And there's reasons why they don't believe that, which we'll talk about. But as an intro into what that will be, patients don't feel early disease. There are very few dental or oral diseases that feel anything early on. Before it becomes irreversible, it's almost impossible for the patient to feel something different. That doesn't mean they don't notice something different. There are some things that they might notice that we'll talk about, but they don't feel that. And secondly, on the other side of the equation, as dentists, the profession in general, we have a really hard time delivering a confident, clear, and concise diagnosis when patients have early disease. But before we talk about those two things, I want to highlight the cost of delayed definitive diagnosis. So what happens to a patient if we don't detect disease early and give them the diagnosis? So the first and highlight study is that when you use, so this was a study done where they took D1 and D3 dental students, so first and third years. They gave them AI assisted training on a diagnostic assistant platform. And those students' ability to diagnose decay increased almost 50%. So 43 to 46%. That's a significant jump in being able to diagnose decay earlier than where we're currently sitting. Another statistic here is what happens when we watch a lesion instead of treating it. So for any of you that have been involved in dentistry and have witnessed in a chair through observation, shadowing, or through your own clinical practice in whatever that looked like, oftentimes dentists will watch things that they're not certain about. In a trial that was studied, what they found is that 1 in 3 interproximal lesions over the course of a year grew. And so the cost of watching is that within a year, a third of those lesions will be worse. More irreversible damage will be done by watching it versus treating it. There are few places in medicine where any patient would tolerate a 1 in 3 chance of the condition getting worse by letting us just sit and watch it. The tragedy in dentistry is that is the norm. We watch early disease much more often than we recommend confident, definitive diagnoses and treatment options. And then perhaps the most problematic statistic is that when you look at a single radiograph, you send that to 34 different dentists, there's a 30 to 72% variability in one study of what was diagnosed. That number doesn't instill very much confidence in how dentists across the country get trained, and then from their training apply what they know in giving patients a definitive diagnosis. That much variability is something that shouldn't exist, because at this point, with the technology we have today, most of our dentistry and our diagnoses are objective. And so I'll have you take those numbers and keep them in the back of your mind as we move forward. Remember, right now, we're talking about helping patients understand what we see and communicate the price of early diagnosis. And I don't mean the dollars and cents, but the cost to delay care on our part for watching, and the cost for them to not take action over something that is early. So on the left, you have where dentistry has been. And this is what an x-ray will look like as it comes off the sensor. And in your current software that displays imaging, you might be able to tune up or down the contrast or the brightness or the grayscale. And maybe you'll be able to highlight interproximal decay between teeth that's incipient. But when you approach this on the left, that's a really hard diagnosis, even for me, to tell the patient, you have early decay on tooth 30 and on 29, and we can intervene today to treat that. It's even having done this for 15 years, I struggle with the confidence because I can't communicate to my patient what that actually looks like. Now, when you overlay that with a diagnostic assistant, I can tell the patient, here's the different colors that signify your anatomy. The teal color is your enamel, and the red color are early cavities. What we don't want is for those red cavities to break through that teal barrier. I'm concerned about these cavities I see. When you think about those two conversations, the one on the left of, I'm not really sure, there's a little darkness here, those are probably cavities, we could do something about it maybe, versus you have this and it can be treated and the patient sees it, those conversations go in completely different directions. Now, the treatment on the incipient decay that we see on the right here, I'm not going to tell you the right way necessarily to treat it, although there are proactive treatments now that can reverse and remineralize decay fairly predictably. But what I don't want the patient leaving is leaving thinking that they are just going to watch something. Because again, 1 in 3 of those, so one of those cavities is going to get worse statistically if we don't do anything about it. At a bare minimum, I need to give them something they can do at home to change their habits or to impact the likelihood of this turning out worse for them, to impact that and drive it down. So this watch it philosophy is deeply ingrained in dentistry. You will see it, you'll hear it, you'll feel it. You probably do feel it and see it in your clinical experience right now. And I guarantee when you get out of dental school, you'll still see it. It's deep in dentistry, and it's something that we can change with the right tools that we have. What you noticed in my conversation with the patient on the right-hand side of the AI-assisted color is that I was not vacillating on the diagnosis. I was showing them exactly what I saw. There's really no disputing what the patient sees either. And now the conversation comes to a discussion around what we are going to do together to solve the problem. Let's talk about 4 common findings that we see often, and these are ones that we miss or minimize. So on the upper left, you'll see occlusal wear and cracks, these wear facets and craze lines. These are the findings that we look at, and we don't really know what to tell the patient other than we'll keep an eye on it until it gets worse. My question to doctors has always been, what is the worst case scenario in that condition? And the most likely outcome is that something will get recurrent decay. A worse outcome would be the part of the tooth breaks and it needs a crown. Even worse could be that that fracture invades and offends the nerve and requires a root canal and crown. And the likely worst case scenario is that that fracture actually extends down through that mesial furcation and renders the tooth non-restorable, and we are now looking at an implant. And that can get even worse depending on the position of the sinus, the quality of the bone, and the quality of the gum tissue. So this goes from I'm not sure about what to do with this crack to we need a sinus lift, an implant, and a crown. Those are very different destinations that we owe our patients more transparency and confidence in our diagnosis. The next one is an early and proximal lesion. I won't go into detail on that one because we just discussed it in length. But these are lesions that aren't quite at the DEJ. We kind of squint at the x-ray and think maybe there's something there. And what's the worst likely outcome? And it's a filling. But for any of you who have had a filling, you know you don't want fillings. I don't want to work on a tooth that doesn't need dental work. The next one on the lower left side, you have these early crestal bone changes that you can see around tooth number 20. How am I going to communicate that to a patient? It is so hard for you as a clinician to point to that tooth number 20 and say, you see how the bone kind of looks like it's got a bite taken out of the top because it should be a little peak and there should be a white line around it, but there's not. And I think you have some gum disease going on around here, but the measurements don't show it. And I don't really know what to do. I don't know how to diagnose and treat this condition. So we just leave it. And then finally, you'll see conditions like this where when periodontal disease isn't obvious, but you have localized inflammation patterns, how do you communicate that to a patient that there's something else going on here, right? There's always a way of telling that something specific is happening, but oftentimes we discount it and say, we're going to just watch this and go home and maybe brush better. Hopefully if you floss, it'll get better and we'll check it next time. So when watch is our diagnosis, the treatment becomes dentistry that's been done for the last 100 years. We have the uncertainty of the dentist. We have the patient who doesn't see a real issue with what's going on because it's not changing their life in any way. So our default action is to watch it. We put a chart note in there that says watch, there's a little eyeball on the tooth or something like that. And inevitably, we don't do anything until something irreversible has happened, until we've crossed a line that now requires restorative dentistry. And my argument is that that's not necessary anymore. We can, with the right tools and the confidence and the right communication, we can help patients avoid the irreversible part of dental disease in many, if not most, cases. And that leads to traditional treatment. So what I want to focus on here is that when watch dentistry is what we do, the patient really never hears a definitive diagnosis. Because we're not telling them they have a specific condition, the patient leaves thinking, the dentist, they're just going to watch it. What is it? Maybe it was a little cavity. Where was it? I don't remember, actually. I'm not sure. Do you feel anything? No, I don't. Okay, then you must be fine. Like that's the mindset that patients get into when dentists behave the way that we do. We're going to move on to our first poll question. So in your clinic or in your experience in clinical dentistry, how often do you see uncertain findings getting watched instead of confidently diagnosed? We'll leave the poll open for another 10 seconds or so. Okay. So the answers are that 27% say that sometimes conditions get watched, or often conditions get watched instead of diagnosed. And some of you said, I just haven't paid attention, which is a very viable answer. Interestingly, though, nobody said rarely. And I would love to have seen more rarelys, because that would mean that very few of you are in a situation where we're doing this passive diagnosis and communication with patients. So thank you for filling that out. Let me pause here and feel free in the Q&A on the bottom of your screen. If you have any questions up till now that you would like me to answer, please, please, please feel free to do so. I will stop and we can talk about any of the things so far that we've seen. And I'll be watching for those questions to come up. So please don't feel like you have to just sit there and listen for the next 40 minutes or so. One of the issues here when we're not confident in our diagnosis is, and when we don't communicate clearly with our patients, is that we, in traditional dentistry and without the help of modern AI tools, we do not speak the same language. So even in a case where you do give a confident statement, like localized 4 millimeter pocket with bleeding on probing and early radiographic bone loss, and all the patient tells you is, hey, my gums bleed sometimes when I floss, or when we give an official E1 incipient lesion diagnosis, but we don't tell the patient that that's a cavity, the patient doesn't hear it and they think I'm okay. So the way that we communicate our diagnosis and our findings versus what the patient hears can be two very different things. Patients believe, for example, that flossing and bleeding they go hand in hand, and that's actually healthy. The statement I take to my patients every day is, my goal for you is that your gums never bleed. No bleeding is healthy inside your mouth. And I don't want to do a filling on you. And so anything that we catch early, I'm going to recommend that we treat it. And patients at first are taken aback by those two statements because they're used to traditional watch and wait dentistry. But with the tools that I have in my office and that we're going to see here in a little while, you'll see why there's such a difference in the ability to bring preventive dentistry to the patient today. So we can be accurate in our diagnosis. We can even chart it and document it correctly. But if the patient walks out and hasn't had a chance to truly comprehend or understand what it is we're telling them, then we haven't done much to shift what we're doing versus the traditional, what we've already outlined as some of the problems in our wait and watch type diagnosis. I alluded to this earlier, that a patient, something they don't say is, when we downplay the urgency of their disease, so if we watch and wait, or I'm not sure, or I think, or it's kind of a little this, the patient downplays the urgency because of what we indicate in our body language and our lack of confidence. And then they pair that with their lived experience. So as I said earlier, there's very few things in dentistry where at the earliest sign of the disease do the patients feel or notice something going on. Cavities that are contained in the enamel don't hurt. Early periodontal disease doesn't hurt. Early occlusal trauma doesn't hurt. Recession doesn't hurt early on. Malocclusion doesn't hurt. Most infections don't hurt early on. And so the things that we try and communicate to patients early on, it's hard because it doesn't hurt them. It doesn't impact their life. So that's one thing we have going against us. And then the second part of this is, up till now, we really haven't done a good job of truly showing a patient what it is they can't see that we can. So early disease, it lives in radiographs and it lives in perio charts and measurements and in very subtle clinical signs that are hard to point out. Even on a single static intraoral photo, it's hard to tell them that this is an ongoing problem. And so instead, we say, let's watch and see if this gets worse. And then if we try our best to compare two periodontal charts with over 500 data points, if it's done correctly, and try and process even just one patient's two different charts or one intraoral photo against one that was taken with different lighting at a different angle to evaluate whether a crack or a recession site has gotten worse, it's virtually impossible to do that. So not only do they not feel it, they can't see it, and it hasn't started to impact their life. Most patients with even severe dental disease are still eating well. They're talking normally. They're smiling just fine. And their lived experience tells them really there's nothing wrong. And so if the dentist isn't concerned about something, why in the world should I be? Because everything feels okay. But symptoms, the lack of symptoms does not mean the lack of disease. And that's where our job needs to change in how we think about that. We need to do a better job at helping patients understand that symptoms or the lack thereof doesn't mean anything, actually, about the status of the disease in their mouths. So this is the chain reaction we're trying to stop. Before, we were trying to stop the watch and wait progression to irreversible treatment or traditional dental treatment. And now what we're trying to stop is what happens when patients don't understand their disease. They don't understand it, so they don't believe it. They downplay it. We downplay it. And so their behavior then goes unchanged. We might softly recommend or unconfidently recommend a treatment, and they're going to look at us and they'll smile and be polite about it, but then they won't do it. You'll hear the number that 30% of patients say yes to treatment. In other words, the average case acceptance across the country for the number of treatments that are diagnosed versus those which are actually completed is about 30%. That number remains unchanged since I graduated dental school. And it's a pretty sorry number if you think about it. That means that only 3 in 10 of what I say should be done is getting done. And I think we can do better there. So what I want to highlight to you all, this is my first real pearl or word of wisdom that I want you to walk away with. Your ability to communicate to patients is not a soft skill that can be honed over years and years or left unfinished as a clinical skill that you have. Your ability to communicate is a clinical intervention. Your ability to help patients understand treatment is a treatment in and of itself. What I have seen over the years as I've mentored hundreds of associate doctors in my career in different settings and scenarios and classes and lectures and one-on-one and chairside, shoulder-to-shoulder dentistry. They want to leave dental school and then immediately go get advanced training in airway management or implant placement or cosmetic dentistry or comprehensive full mouth restorative dentistry or endodontics or the complex clinical dentistry. And my advice to you is to pause and think about how important your ability to communicate clearly with a patient is. If the tools and the skill sets that you learn help you communicate disease and conditions and outcomes better, then all of the other clinical treatments that you and go and get advanced training in, you will do more of them sooner in your career than if you go spend years getting advanced training now and leave behind the ability to communicate that. I see doctors all over the country who go and get advanced education and then they blame the DSO or the private practice doctor that they were with that there just wasn't enough dentistry to be done, when in reality, they are poor communicators and patients don't say yes to their care. I want you to think of your ability to communicate as a clinical intervention or a treatment rather than a nice to have skill. There's a reason for that we'll talk about more now. When you pair clear communication with clear teaching or education, which involves visual dentistry, magic happens. So there's a principle in cognitive science that demonstrates this. When you look at the image on the left, all of us can look at that and say, okay, it's obviously a dental x-ray. It's a bite wing. It's of the left side. I can see, you could number the teeth there and you'd be accurate. You could maybe even say that tooth number 14 has a restoration, maybe 15, but beyond that, the image is pretty blurry. When you look at that and compare it and contrast it with the image on the right, there's a very different visual impact. When you as a dentist try to explain to a patient what's going on in an x-ray, because they have no ability to comprehend a black and white x-ray, when they leave your chair, all they remember is about as good as what's on the left there. It's about a 20% retention rate of what you said. If you can go and show them something on the right and say, here's the anatomy of your tooth. The red is a cavity. The pink is this, and the purple is that. Your patient will be left with a much more crisp image of what was going on. And it's because we understand color. We understand this contrast. We understand with our eyeballs in a language that's very different from just simply listening to a dentist explain something that otherwise looks like toes or something foreign, which is what you'll hear patients say about dental x-rays fairly often. We're going to shift gears now and talk more about the different tools. So there's three main categories of AI tools that we're going to discuss right now. They all have one purpose, though, and that purpose is to bring clarity to the work that we do and the conditions going on inside their mouth. The first condition, or the first category, is diagnostic AI. So you've seen several images up till this point, but what the diagnostic AI is doing is it's overlaying over our x-ray, primarily our x-ray images. It's catching things that sometimes we miss or that we're not confident in diagnosing off of a black and white x-ray. So caries detection, you've seen that, bone level analysis, calculus, apical lesions, and even marginal integrity. So on an x-ray like this one, I can tell the patient they have an area of bone loss, 2 areas of bone loss. They have an existing root canal. There's a crown with a questionable distal margin, and there's a potential infection growing at the root tip there. And in one image with one AI overlay, I can confidently show them an otherwise unintelligible and almost impossible condition or several conditions that would communicate active disease going on. Now, with all of these AI categories, I want to be clear that the AI is not making a diagnosis. So at no point is the AI saying this patient has active periodontal disease on the distal of either of those teeth. And it's not even saying that they have an active lesion. That's your job as the clinician to look at that and say, hey, I agree, there is something going on here. Or, you know what, we just did that root canal 6 months ago. This is an artifact of what was there before. Or you have recession and a reduced periodontium that's healthy at this point on the lower left quadrant that's not active disease. You see, that's up to us to make the diagnosis there, but you can see the value in showing a patient what's going on here. The second category are these visualization technologies. And when you bring these into the operatory, what you move away from is us staring at the clinical or the diagnostic information, the x-rays, the charts, the measurements, and you pull the patient into a co-diagnosis discussion. And this is the moment where everything we've talked about starts to converge. We as clinicians can confirm things that the patients can see. And for the first time, the patient just isn't being told something that's kind of nebulous and they're listening to it, remembering only 20% of a fuzzy image. They're seeing it in clear, intelligible, and understandable formats that they can understand. So this is a real live interaction that I had with a patient of mine, and you can see how he is leaning in and hearing and understanding, comprehending what's going on inside his mouth in a way that I just couldn't do otherwise. And it's the AI technology that's making this possible. AI visualization, two scans of the same patient taken 15 months apart and show them what's happening inside their mouth in a way that was impossible prior to this. I can keep the models in a color rendering mode, or I can take a stone model version and really highlight the areas of recession and the areas of attrition happening on their teeth. I can show the heat mapping of their bite, and I can show them how this has changed over time. So over 15 months, the occlusal pattern on this patient has shifted from being primarily posteriorly heavy to shifting towards an anterior pressure on these teeth, which is causing some attrition on the lower anteriors. Technology like this enables a patient to ask exactly what's happening, how they can fix it, what the appropriate treatment is. And it doesn't require me, the dentist, to explain in great detail the treatment modality. I can simply say that they need to realign their bite or optimize their occlusion to prevent further destruction from happening. I hope with that demonstration, you're able to see the power of what visual AI technology is doing for us. So this is the second category of AI dentistry. And it really is changing how patients interpret change over time in their teeth and why treatment today matters so much. This patient saw some of the recession in a way that she had never seen it before. She saw very minor changes in her enamel that I could then point out. And she decided to move forward with treatment to realign her bite and position the teeth better so that occlusal forces weren't causing this destructive bite to continue onward. Had we just left it, the teeth would have become more crowded, which is an aesthetic issue for most people. But the real functional concerns about gums receding and enamel being lost were what drove this patient to say yes to care that I never would have been able to communicate this otherwise. And so this goes beyond taking an intraoral photo and gives patients real color to the disease and the ongoing process of destruction that's going on inside their mouth. And color is this language that patients already speak. So this is where there's a connection between diagnosis and prevention, and it starts to feel obvious. When patients can see their own wear progressing year over year, or their occlusal disease, and what it's actually doing, it stops being this abstract thing that they don't feel. They start to get really concerned about the fact that they've lost 50 microns of enamel that they're never getting back. When you explain it that way, their call to action, they perk up in the chair and ask, what do I do about this? So it stops becoming a chart note and starts becoming an action point for them. And this visualization technology that is propagating rapidly throughout dentistry is giving clinicians and patients the power to have these types of conversations. And all of that, I would argue, is the earlier we catch it, the more preventive it becomes. The third section, or the third category of clinical AI tools, is the documentation and scribe tools. So what happens here is, because you are no longer constrained by a note template that requires typing and clicking, what I see happen across the country and offices all over is that clinicians are having better conversations with their patients. They're taking far better notes. and they're getting better diagnoses with significantly less administrative time on the back end. So these AI tools are capturing conversations, they're understanding what's being said, who's saying it, what kind of diagnoses are being delivered. They're helping interpret and process treatment plans. They're facilitating diagnosis, not giving, but facilitating it. And they're helping to standardize records in a way that we've never been able to do before. You can see here on the right on the image, this is a tool that I use that very quickly helps to summarize my periodontal disease discussion with patients. It recommends, based on what it knows about me and what my clinical preferences are, what stage and grade I would likely give this. I can edit that and confirm it. And then what treatment modalities I'm going to recommend to treat the condition based on the chart. That saves me a whole lot of time, and the risk or chance that I'm going to vary from my clinical protocol on how to treat one patient versus another that presents identically in terms of their attachment loss and inflammation. And so for something like this, the AI tool helps me to standardize my care, even in the small office that I own and work in. So all of these things change when you start bringing these clinical AI tools into the operatory. Now, there are some trade-offs. AI is really good at pattern recognition, consistency, and documentation. But what we fear and what happens is we worry about it becoming the diagnosis, which it is not. We worry about what the patient's going to think or feel about the fact that we're using this technology. We're not sure whether the patient's going to accept the recommendation. And I will just tell you that in my experience across offices all over the country is that patients are widely accepting of this as an adjunct to their clinician, not as a replacement to their clinician. And let me just share a little bit of context. I have been involved in clinical AI for over 6 years. Since before COVID hit, I was working with different AI companies in implementing AI systems at scale. I bought my own practice in 2024 on the premise that we had enough AI clinical tools to build a completely different prevention-focused practice rather than a practice that does traditional dentistry that then brings AI tools in to help them do more dentistry. I think that there's a fundamental shift that can occur, and it's all built on AI technology and how it's able to help us identify, communicate, and prevent disease early. I do hear concerns about clinicians saying that it will overdiagnose, that my patients won't trust it, and that it'll actually slow you down. And some of those concerns are valid, I'll be honest. But what the clinicians fail to realize is that you get to tune most, if not all, of the AI tools that you use. Patients, as long as they see you interacting with the tools in a way that's objective, they will trust what you show them and what the AI shows them, and there will be a convergence of understanding there. And the idea that it's going to slow you down, there is a workflow change to a lot of this. It does require some getting used to as you start to implement these tools in your clinical practice. After you go through that initial hurdle of change, though, the time saved in the background is significant. We're moving on now to our next poll question. So let's go ahead and open the poll. Which AI tool right now would have the biggest impact in your clinical experience? So we talked about the three tools: the diagnostic AI, the clinical visualization tools, the scribe and documentation tools. Which one would have the biggest impact on your current clinical experience? All right, we can go ahead and close the poll there. So the clinical visualization tool, I would agree with that, actually. That's interesting that you'd say that. The AI, the scribe and documentation, it's really nice when you're typing up 15 or 20 notes at the end of the day. I think in dental school, it's not quite that burdensome. But yeah, those clinical visualization tools are powerful. I agree with that. Thanks for sharing that.
And before we move on, just a quick question from the chat. What would you estimate the treatment acceptance rate to be when using these tools as compared to the 30% you shared earlier?
I would say it's very easy to go from 30% to the mid 40s and low 50s. So patients inevitably aren't going to say yes to everything. I don't think there's any way to do that. But I think on average across the board, I would expect them to raise the case acceptance into that range, 40 to 50%. And for a clinician who's focused on communication skills and emotional intelligence and empathy, you can push it far higher than that, 70s and even 80s percent. So I've seen numbers and data that would support that as well. It's not general across the board though. That's a great question. Thank you.
And one more before we move on that came through. In your experience, how accurate is the AI tool in showing what's actually there clinically?
So I think it's really right now there's 4 or 5 different imaging platforms that are all really good. Some show different disease and decay and other things better than others. I would say by and large, they're all really good at incipient or initial decay. Some of them get tripped up with large decay that should be very obvious to us. They're really good at identifying existing conditions and tooth anatomy. Apical lesions, I would say, we're not quite there yet, especially on 2D images. I think when 3D becomes more ubiquitous and the AI to process that becomes more ubiquitous, the apical lesion diagnosis will skyrocket and it'll be crystal clear to diagnose that. The bone loss, I think, is very accurate as well. So really good question. So we're going to take this now, why early detection is the foundation of prevention. And we're going to give you this 3-step patient conversation tool with, if I'm sitting in your shoes, that I want you to follow. So if you can't show them the finding, then you're going to just be in the 30% of case acceptance range. They're going to remember about 20% of what you said. It's going to be this fuzzy image, and you're going to struggle to get patients to say yes to care. If you can't name it in simple terms, then you're going to struggle to get case acceptance. And if you can't connect it to their life and why it's going to impact them, then you're going to struggle as well. So I know you don't have control over exactly what you see here, but because you don't have control over what AI tools are being used in your office. But as you think about how to use whatever tools you have available, how can you show them what disease looks like? Whatever you can do to show them in color what's happening will improve their ability to understand and say yes. I want you to think about naming the disease. So oftentimes you'll hear dentists, you'll hear your instructors, your clinical floor directors, you'll hear dentists out once you graduate say, there's a little cavity or maybe, and we've already talked about this, your gums are a little inflamed. They bleed just a little bit. And we're going to keep an eye on this. And what I would challenge you to change today is your ability to confidently say, this is a cavity. Don't make it smaller. Don't make it anything other than the fact that it is a cavity or it is infection. It is a disease. It is cracked, right? Whatever the condition is you're calling, don't use any other descriptor other than what it is. If they have any kind of bleeding in their gums, it is a gum infection. It might be gingivitis. It might be localized gingivitis. It might be localized gum disease. It might be stage 1, 2, 3, 4. I don't really care necessarily, other than that bleeding gums are infected gums. They always are, right? There's no world where a gum bleeds, a gum tissue site bleeds, unless you're iatrogenic. But the reality is gums bleed because they're infected. And things like bite destruction, I wouldn't use occlusal trauma and malocclusion. Like, patients don't understand that. You're destroying your enamel. Your gums are pulling away actively from the bone. Like that's recession. Think about a way to give a confident, simple word for the disease that they have going on. And then figure out a way to connect it to their life. This is why your gums are bleeding when you floss. This is why the tooth feels different to hot and cold. This is why it's sensitive. This is why the gums are pulling away. This is what happens if it's left untreated. It's going to become like the other side or this other tooth or that root canal you have. And so if we are proactive about treating this, we can avoid that outcome. So those are the three things that I think make a huge difference in your ability to help patients say yes to care. And that's, again, to show them somehow visually what's happening, to name the disease confidently and simply, and then connect it to their life and what happens if it's left untreated. So up till this point, we spent the last 50 minutes talking about what happens in the operatory. We're going to shift gears now a little bit, and we're going to talk about what happens at home, because a patient spends 2 hours roughly with us a year. They come twice. Now they might come for another visit, but the reality is we're talking 3 orders of magnitude more time spent outside of our office than with us. And to expect that what we do in 2 hours is going to set the course for their oral health is silly. It's just not reality. And so with the amount of time that they spend outside of what we're doing for them in the chair, what they do matters. So yes, what we do in our chair matters to them, but what they do at home is actually going to drive prevention versus a regression of their disease to a state of irreversible treatment that then we have to fix. And so this is where the home care section of this actually matters. And we'll talk a little bit about how AI is helping us there as well. So if you recall, your ability to communicate is a clinical intervention. Your ability to prescribe home care in a way that they take action for it is huge in the outcomes of the dentistry that we're trying to prescribe now in a preventive way. Their daily biofilm control matters more than ever. The tools they use must be effective, and the habits that they use have to match the diagnosis. If we don't give them the foundation for daily plaque control and why it matters and how they're currently doing in that effort, whether it's most of the time failing versus doing really good, we're not helping them understand that their habits aren't actually helping. If we're not recommending effective tools, they're going to just continue working with bad tools. And if we're not helping them identify habits that will match the diagnosis of what they have going on in their mouth, then we're not doing them any justice either. So for example, if my diagnosis is you're a high caries risk, if I just said brush and floss, that's very different from saying I'm going to recommend this specific power toothbrush, and I'm going to prescribe you a prescription strength toothpaste, and we're going to increase our recall frequency. I want you back every 3 months or every 6 weeks or whatever it is to apply a topical fluoride varnish because I'm concerned these cavities are going to get worse. That's a very different home care regimen and recommendation than, hey, brush and floss, let's check you again in 6 months. If my diagnosis is generalized gingivitis, I might say, we need a prescription mouth rinse. I need this specific power toothbrush with this head on it to make sure that it cleans in between and underneath the gum line. And I need you to use a power flosser because you're not doing a good job with regular string floss. Or if they have occlusal wear, I need you to do some things and wear a night guard, and you're going to change your habits around that. You can see that my recommendations for what happens at home are very different if I've given them a diagnosis. And if I take it seriously, the chances at prevention are much, much higher. Here's an example from one of the tools that Philips had with their 7400 series toothbrushes that closes the AI loop at home. So we've done all this AI in the clinic chair, but what we haven't done is given that to the patient at home. And what we've said up till this point is to say, hey, go brush your teeth and then come back. And I ask them, are you brushing for 2 minutes? And they say yes. and I'm looking at their gums and I'm thinking, but you're not, because there's still inflammation. You're not doing a good job. And you can disclose and like show plaque and all that, but some of these tools now use artificial intelligence to track habits, to give feedback and information, and to communicate with clinicians. Here's how good this patient is actually doing at brushing twice a day for 2 minutes in the right places, the way you discussed. If we can't give patients these tools and recommend and emphasize the level of importance, then we're going to fail with the most important part of their prevention protocol, which is what they're doing at home. So we're about ready to close. We'll have our final poll right now. What do you think is the biggest barrier to patients changing their home care habits? So they don't believe they have the disease, they forget, they don't have the right tools, they don't actually think it's going to make a difference, or maybe something else. We'll leave this open for a couple more seconds here. Okay, so we're more split on this one. I think they don't, yeah, we're almost split evenly, other than that they forget the recommendations. So the biggest one is they don't think it will actually work. Yeah, I think that's right. I think patients actually often will have a fatalistic view where they say, you know, I try everything and it just doesn't work. I still end up with these problems. And what I would argue to the contrary is with the right tools, communication, and home care protocols and home care tools, you can prove to them that it actually will work. So thank you for that. We have this loop now that we've covered. We've talked about using AI to help you diagnose and demonstrate more confidently. We've talked about how it can help you communicate more clearly. We've talked about how it can help you recommend more specifically, and then how you can reinforce that with better home care tools and protocols. And all of those now have these clinical AI tools that help you do all of this and yield better, more proactive and preventive dentistry. I love that we're here in the profession. I couldn't be more excited about the future and what is to come. If I were graduating dental school, but knowing what I know now myself, I would be so excited with what I'm going to be capable of doing for my patients throughout the course of my career. Here's 3 things to maybe think about. You don't have decisions to make clinical AI available in your dental schools, but you can take and compare 2 of the platforms or platforms that we've discussed out of the 3 categories and make a comparison and decide for yourself which one would you be most excited to use, or which one would you implement in your practice, or would you like to see in your practice, and why. All of you can definitely do number 2, which is to replace one vague phrase or one diminutive phrase that you make and pair it with a specific diagnosis. And then the other challenge I would have for you is to think about a research-based home care protocol that you can stand up for one of the common diagnoses that you see in dental school. Pair that with a home care regimen, with products that you think will work, with tools that you think will actually help a patient to succeed with that, and start thinking about how you want to communicate that to your patients. I want to thank you all for your time today. We will stay after for Q&A for a few minutes if you want, and that Q&A section will remain open. If you want any more information about some of the products and the tools that we talked about, you can go to the Philips Sonicare website or scan the QR code for more information. Thank you very much.
You do have one question in the Q&A that you want to address?
I sure do want to address it. Let me take a peek at it here. All right, so clinical visualization are super powerful, but we are not hoping to get patients to accept treatment in a school setup as much as practice outside the school, but diagnostics can vary so much. Let's see, residents and students in school. What would help align the varying providers the patient sees in school? What do you think? So, yeah, the question around the fact that they're seeing different providers, different specialties in school. I mean, look, that's really hard. How do you improve that? I think if you had these tools, the only thing you can do is systematize how you approach it and the confidence with which you use it. You're not going to be able to align what different departments, different students, different clinical administrators or directors, floor doctors or whatever they're called in your school. Like, you can't change how they're going to approach it, but you can have control over your ability to speak confidently and to let the patient sit there with that. And the hope is that they'll look at you and say, man, I trust you more than I trust the other people, and I want you to do the work, or someone else I want to do the work. It just needs to get done. So take control over what you can control, which is your confidence, your diagnosis, and your conversation. Great question. Really tough one.
We do have time if there's anybody else who want to ask Dr. Burr a question for anything that he's covered tonight. We still have time for a couple more actually.
Let's see here.
There's another one in the Q&A.
I feel some patients are skeptical of AI altogether. How would you address that? I disagree that they're skeptical. I think they track what the clinician feels about it. And I have clinicians that I work with who are very skeptical about overdiagnosis or the computers are taking over. And so they don't use it. And then they come to me and say, yeah, my patients don't agree with it. So I use AI every day in my practice. I use it to answer my phones. I use it to schedule patients. I use it to bill and to submit insurance claims. I use it to help diagnose on x-rays. I use the visualization technology. I use voice technology. I use it everywhere I possibly can. And I tell patients, so they sign a disclosure knowing that I use it all. And I'm only going to use my experience and say that I just don't think that's true. I think patients see it, and when they understand what it's doing and why, they start to embrace it. And I'll be honest, when I tell them I don't think it's good, when patients call and they say, I want to speak to a human, and I pick up the phone, or someone else picks up the phone and they say, I hate your AI receptionist. And I say, you know what? You're right. It's not perfect, but gall, it really helps me answer phone calls better. And it helps me keep my prices down because I have one fewer person up front, and I'm able to prevent more dentistry because of it. They gain an appreciation really quick for what I'm trying to do with it.
Any other questions? Doesn't look like we have anything else. So, Dr. Burr, I just want to thank you. I think this was a great and informative talk. And I also want to thank Philips Sonicare for their sponsorship and support of this webinar tonight. As you saw the QR code, Dr. Burr mentioned earlier that Philips Sonicare has that QR code so you can find more information about the company. But if you're interested in viewing this webinar again, it will be posted in 1 week on ASDA's YouTube channel, and it'll also be saved to the webinar directory on ASDA's website under programs and events, and then right under webinars. We also will send each of you a reminder when the webinar is available on the website. So again, Dr. Burr, Philips Sonicare, we thank you for a very important discussion, and we look forward to working with you again in the future. And thank you all for coming tonight.
Appreciate it.
Good night, everyone.